Hello, everyone, and welcome back. Today's topic is going to be something that scares all of us, the derogatory term, crazy patients. And I'm sure many of you have those patients, you see them in the schedule and you just get worried. But if you've seen some of the longer lectures I've given to the residents, what I think is actually going on here is hyperinflammation, which is where you have chronic tension, stress-related somatic symptoms, and central sensitization. And the reason we are all scared of these patients is because they're the ones where it's more difficult to diagnose, and it's often the ones who are going to have the flare-ups and be calling you after hours and requesting pain medications and all those things. So they tend to be more difficult to work on, more difficult to treat, and more difficult to get a good outcome. So let's go into the case today. This is the x-ray. As you can see, not much going on here. What were her chief complaints? Well, we have 10 out of 10 pain. We have hot, cold sensitivity everywhere. We have biting pain everywhere. And her symptoms went both along the maxillary and mandibular branches of the trigeminal nerve. So she's pointing all the way along from the ear to the midline on the maxilla. She goes down the angle of the mandible to the midline of the mandible as well. So very difficult to figure out what's going on here. So let's take a look at the medical history and see if anything stands out to us. We can see that they put in there current infection, back right. They're taking a few different medications or supplements. There's a history of some mental health disorders. They bruise easily. They do have some lymphedema in the lower left extremity, history of migraines, and they've taken prescriptions. So I know ashwagandha, but I'm not sure about Better Bur and saffron. So there's a great resource called examine.com that I use whenever I need to look up why a patient might be taking a different supplement. So these are the responses from that. Butter Bur isn't butter beer like from Harry Potter. It is used for migraine prevention, and don't love the falling out of favor due to the risk of liver toxicity, but we're not counseling the patients on that. Just know that she's taking it for migraines. Saffron, not only is it delicious, it's used for depression and also anxiety. And then ashwagandha is not only used for stress and anxiety, there's a few other benefits as well. So when we're looking at the supplements that she's taken alone, we already have 1 for migraine prevention or to help it, and 2 for stress and or mental health. When you have patients who are taking supplements, one thing to consider is that they're probably more proactive in general. The fact that they've looked up things that are outside of the traditional system of medicine means that they're going to take more of an active role in managing their health, which I think is actually a really good thing. So let's look at the prescription medications now that she's taking. And as you can see, there's a few here. So let's go through these one by one. Starting off, she's taking a medication called Nurtec or Rimegepant. I'm really good at saying drug name. For being married to a pharmacist, you think I'd be better at this. This is for both acute and preventative migraine treatment. So another one along with the Butter Bur thing of prevention of migraine. So we can tell already, all right, we got some headache history. What else do we have? Next up is bupropion or Wellbutrin. It's a norepinephrine dopamine reuptake inhibitor, which is used for a variety of different depressive states. So when a psychiatrist or medical doctor is going to be treating some type of depression, they oftentimes are going to have to use a combination of multiple drugs, and that's what we're seeing here, because not only is she on the bupropion, she's also on gabapentin. So that's the GABA analog. It helps with both neuropathic pain as well as anxiety. It can be used for seizures. It's used quite a lot for a variety of different maladies, and you'll see a lot of gabapentin being used. Next up, we have Lamictal or lamotrigine, which is a mood stabilizer. So it does say on here that it's for bipolar disorder, but oftentimes when we are treating more aggressive forms of depression, I'm not sure is aggressive the right word, but more severe depression, they'll start to add on different categories to see if that helps with the patient. And if you look back at her medical history, she's using it as a mood stabilizer. So even though it does say bipolar on here, it can be for mood stabilization as well. Next up is Celexa. We have yet another type of reuptake inhibitor. This time it's going to be a selective serotonin or SSRI, another thing that we take for depression or for anxiety. Also have Valtrex. And so you may be thinking, why is the Valtrex important? Well, it's an antiviral, and it works primarily on your herpes viruses. And the reason why this is important is because herpes viruses are oftentimes if you have immune suppression or high stress. And so we can already see this patient has probably a lot of stress. So these are things that you need to be thinking of in the back of your head, that we have these chronic stress issues going on. And so because if you're chronically stressed, you have immune suppression, they're probably at a higher risk of having, frequent cold sores come up because of those high stress, which is why she's taking the valacyclovir. Very normal. All of us have herpes inside our body. Just heads up. It loves humans. Next up is going to be metoxalone. And so this medication is used for muscle spasms. This is also called Scalaxin. And so that plus her Xanaflex or tizanidine, both of these are going to be for muscle spasms. If we look at the medical history and why she's taking it, it's for muscle spasms and for migraine. So in this case, I'm going to assume that the neurologist is thinking that it's a hyperactivity in the muscles that is causing her to have the migraines. And so just another thing to in the back of your head, we're on 2 different muscle relaxants here. And then finally, rizatriptan. This is an abortive medication for migraines. So when they are actively having a migraine, this is a medication that can stop the migraine and abort it immediately. So what we have at this point, we have multiple medications that we're taking for migraine. We might have a history of neuropathic pain. We for sure have some muscle spasms, chronic pain that could be leading to TMJ issues. It could be related to the chronic migraine. So you know that we're probably having some of that somatic pain from the chronic stress. Then we look at the psychiatric mood disorders. So we probably have a history of depression or anxiety because we're on Wellbutrin plus Celexa plus the saffron plus the ashwagandha plus the lamotrigine. So she's on multiple medications specifically for that combination of psychiatric and mood disorders, which tells me we probably have a history of anxiety and for sure doesn't like the dentist. I know that's a surprise to everybody here. Patients like this, it's really important to have empathy for the fear that they're having and what they're going through. And the fact that someone who is going through this process is going to have a lot more pain than someone who isn't going through, doesn't have that chronic stress. And then the viral suppression, that's the one that I think not many people think about. It's not necessarily that, oh, you go out in the sun, you have a cold sore. It can also be, I am chronically immunosuppressed because I'm going through such a high stress, and that will lead to more frequent herpes outbreaks. What you see here is that this patient is proactive. They're probably seeing multiple specialists, which is very frustrating, and they're coming in to a place that they don't like with 10 out of 10 pain that's hard to diagnose. So what do we do next? We see them. That's the one thing that I didn't mention here. I did all of this before going in to see the patient. And I did have a heads up. Thankfully, the dentist did warn me. You can see the message here. Thank you in advance for seeing this patient. Really bad facial pain. Could be perio. Could be facial pain. Dr. Kim is the new oral facial pain specialist who joined our practice. And the referring dentist sent this patient specifically to me on a day that Dr. Kim would be here so we could kind of look at both of these. But it's really nice that I was able to get a heads up. So if there's any general dentist watching this, this is fantastic. It makes it so that we come in and kind of treat the patient in a different way that more allows us to specifically address their anxiety. So when we see the patient, in addition to doing our normal intraoral examination, I'm going to do a more thorough muscle examination, looking at the muscles of mastication, primarily to see are there any trigger points that could be contributing to this pain. We'll definitely take a look at the TMJ because there's a really common overlap between pain from the joint that can also manifest as facial pain. And then the other one I'm going to do, you see that TN, quote, quote, that'd be your trigeminal neuralgia exam. So a patient who comes in with this many red flags in the medical history, 10 out of 10 pain, and that it hits both V2 and V3, you should have that in the back of your mind, that this could be some form of trigeminal neuralgia. And generally, you can have atypical ones, but generally there's going to be a spot or some spots on the face that will trigger this. And so you kind of just gently palpate along the area that the patient is saying is causing pain and just see if any of that triggers the pain, because that would give you an idea, okay, there may be something more going on here. As far as what was going on with this one, the tooth was dead. So this made it a lot easier to figure out what's going on because the tooth is necrotic. So tooth is dead. So we're going to go ahead and do the treatment. Okay, so before we go forward with doing treatment, let's talk about setting yourself up for success. And so on a patient like this who came in with such a high amount of pain where you're suspecting that there might be something else going on, it is very important to set the bar really low. And what I told this patient is, for sure you need a root canal. Your tooth is dead. I didn't go through the cone beam because this video is already long enough, but there's a tiny, you wouldn't know it if you didn't look at it, but there's a small little spot on the cone beam. And so for sure the tooth needed a root canal. I accessed it. It was definitely dead. You'll see that in the video in just a second. But this may not fix all her problems. And that's exactly what I said. We know for sure that this tooth is dead. It needs treatment, but you might need something else. So before you jump into treatment on a patient that comes in with these red flags in the medical history that might have something else going on, kind of in that oral facial pain world, it's important to let them know that yes, you for sure need this, and it should make things better, but you may still need some extra treatment as well. Let's go ahead and jump into treatment and some of the modifications I do to make it more predictable on patients with so many red flags in their medical history. So it's been a few months because reasons, but here we are. We're going to finally get to how would we do the treatment. So the access is pretty much the same as any other tooth, and really the treatment itself is pretty much the same as what we would normally be doing here. It is a zirconia crown, so we will be accessing using those Brasseler purple burrs. You can see when they go, they leave that black mark. That's when all the diamonds just kind of go off all at once. They leave a little burn mark, and you just switch it out for a new burr. That's what that little black mark was, in case you're wondering. Lots of water on these is the best way to deal with that. And eventually you'll get through to the tooth structure, and all of a sudden your life becomes a lot easier once you get through the zirconia. And once you're through that spot, it should drop down nicely. That's the tooth there. That's no longer a burn mark. And we go in with the workhorse, and it becomes much easier here. As far as the actual treatment itself, I don't change much in terms of the root canal when I'm working on patients who I think may have a few other things going on. It's more of when do we finish the case. And this is, everybody has their own preference here, but I like to finish the case once I know they're asymptomatic, because it helps the patient build trust that they know it's not the tooth. And as you will see, the patient actually does come back a few times thinking it's the tooth, and we actually have a few other things that are going on here as well. So when I just said, make sure you prompt for, we might have to go to perio, we might have to go to oral facial pain. Guess what? We had to go to perio, we have to go to oral facial pain. So there's a reason I'm telling you all this. As far as the treatment, very straightforward. We're going to go down with a 2006 and 8 like we normally do. We rinse it out with Triton. This is, if you've watched anything on this channel, this is how we do pretty much every root canal. Like I said, there's not much I'm changing for the root canal in the day-to-day. It's more, we're going to modify how we finish the case here. So I put this in just because I feel like I haven't done a clinical one in a while, and I wanted you all to see this. But the case itself is more on how we set it up for success, and then how we're going to handle it when the patient inevitably does come back, because heads up, she does come back. The case itself is kind of fun because the shape is a little bit different. It almost morphs into this weird, like, two canal looking thing. You'll see from the final images here. It's definitely different than, say, a normal looking tooth, but kind of a fun one here. As far as the rest of the treatment, it's, this is a normal root canal for us. It's nothing that crazy. We're going to go ahead and get the working length just like we always do with the 25 millimeter 10K file. Make sure that's nice and accurate. If you need more information on this, you can watch some of the earlier videos, but make sure you go all the way past, back it up. My friend Matt Kinsler just actually did a nice little lecture on that for all of us, showing that you really do need to go all the way to the 4 red bars and back it up to 0, 0. That is the most accurate point for your measurement. Anything, even if you go just to 0, 0 and back it up to 0.5, you can still be quite short. So you do want to go long on here. Now, what we're doing, I am speeding up a lot of this here because, once again, it's just a regular kind of boring. Besides the patient itself, it's more just kind of a boring case. I am going to go through activate. So this is one thing I am doing a little bit differently here. I'm more on a case where I knew I would be doing a calcium hydroxide. I normally wouldn't be activating. In this case, though, I wanted to have just kind of throw the kitchen sink at it, just best chance to get everything cleaned out there. So I did throw the activator. It may have also been because the assistant handed it to me. I don't remember at the time. We have a rule in the office that if they hand me something, I will use it. And so I think that may have been why I did it here, but it's not going to hurt anything to give it a little bit of a little wiggle and just knock some crap loose inside there and go from there. Dry it nice and as best we can, but you'll see there's a lot of inflammation in the palatal. No surprise here. We knew from going through everything that we've spent the first 12 minutes of this video doing that the patient has some hyperinflammation. If you need more information on how to stop that bleeding, I'm using the exact same technique that I showed 2 years ago. Get inside there, see if we can't get it to dry, but unfortunately we still had some bleeding, and so I was kind of planning on doing this 1 and 2 visits anyway, and still had some drainage, which we were, like I said, we were planning on putting calcium hydroxide in this one anyway. It has been a minute since I made this video. If I didn't put this in here, I'm sorry, but calcium hydroxide does help with inflammation. I think I put that in there earlier. Sorry, it has been like 6 months since I first started this because I was actually waiting for the finish of this, but you'll see the original, I think the original in this one was in like June or July, and we finally have her scheduled for the finish in December. So I'm recording this voiceover in November. The other voiceovers were recorded a while ago, but I was trying to get a final picture, but we had this one out for so long. I was like, fine, we're gonna finally get this one out to everybody, and I'll post the final just via a regular, just still post when you guys want to see it. Regular caveat for this one, nothing crazy here. We ended up seeing her back and had to change to Vitapex. You'll see that, and I did switch to using just flowable composite. But this is the first thing that we do differently. I'm going to be very aggressive about adjusting the bite here. Not only did I have to spend almost like 5 minutes adjusting the bite here, some of this is cut out just to make it so it's not so terrible for you all. I actually had to bring her back in a month and readjust the bite even further because things had shifted and she still had those non-working bull interferences pop up, even though you'll see I spend quite a lot of time getting everything perfect here. So I really am, when we talk about adjusting bite, anything on the buccal of the upper or the lingual of the lower, it's getting adjusted out. And we're trying to see that she can start to disclude those posterior teeth. You'll also notice that as we start to go through this process, the marks actually get heavier. This is counterintuitive to a lot of people. But what will happen is there are these mechanoreceptors inside the periodontal ligament cells that actually tell and give feedback to the masseters and other muscles of mastication how hard they can bite. So you may notice this when you start to adjust the bite. Don't just do it once. You have to go back and recheck it because you'll see that there might be these tiny little pinpoint ones. You saw when we first started here, it wasn't hitting that hard. And then all of a sudden now we're getting heavier and heavier marks. And that's because even though the patient doesn't realize that she's doing it, they're actually biting harder and harder. Look at how heavy the marks now are on those first molars. And they're biting harder and harder because the muscles are realizing, hey, we can now hit harder because those marks aren't there anymore. You'll see those little beautiful sparks from zirconia. That's totally normal. It is a metal. Tell all the natural dentists that. And the point here is you really see the marks. It's fascinating to me how this works, that as you start to do these adjustments where they were barely touching in the beginning, as they're adjusting, they keep getting hit harder and harder, and you can actually see a little bit of movement in the teeth. So she has been hitting so hard on these, there is actually mobility on the teeth. That makes it a little harder to get a pretty stable bite as well, so don't be surprised if you do have to bring the patient back. You may notice this at that 1 month recall as well. If a patient comes back and says, oh, I still have pain every now and then, especially to pain when flossing. That's one of the best times. You'll see here I give an injection of dexamethasone as well, something else that we change. So there's the image from July. That's the regular calcium hydroxide. She came back a month later. We ended up remedicating with Vitapex at that point because we were still having some issues. Then she came back 1 month later, still having some pain. We didn't end up opening things back up because it looked good on the x-ray and on the cone beam. But what we did start to talk with her about at that point was the gingiva. And so I had this drawing that I was showing her, and we had talked with her about this initially, that she did have a little bit of bone loss here. So she's going to be going over to see my periodontist friends to do some work in the area because her pain wasn't actually from the teeth anymore. It was from the gingiva, and she has gone over to see the orofacial pain specialist. So she is scheduled to come back in December to finally get everything finished. I will post it then. As always, thank you all so much for watching. If you have any questions about this, please let me know, and I will talk to you all next time.